Okay, thanks everybody for logging on. I hope you're liking the conference and will continue to like it. Um, I'm very excited about my guest today, Brent Stackhouse, to help me come through a guided conversation of investing in healthcare. Brent is a perfect person to speak about this because he is currently the managing director of Mount Sinai Ventures, the investment arm of Mount Sinai Health System in New York City. We'll talk more about his role as we go through this, but he's involved in early stage medical venture investments and corporate development. I work with him on many ASC projects, and he represents Mount Sinai on many of the portfolio companies. He's a very busy fellow because he's also the senior partner of Specs Capital, which is a UK-based early stage health tech ventures. And I don't know when he finds the time, but he's also doing educational philanthropy with various institutions. So Brent, thank you very much for joining us. I appreciate your time.
Thank you, Andrew, for having me. It's really exciting to be here. It's great to join Garfunkel Wild in this conference once again. Garfunkel's been a great partner to a lot of our portfolio companies, representing our portfolio companies in all of their needs, whether it's contractual or mergers and acquisition or divestment. And it's great to be able to tell you a little bit about our work.
Great. So I'll tell you how I was thinking about getting into this. Investing in a movie theater chain is not the same as investing in a medical related enterprise. And it's also different when you're representing a major health system. So why don't we start from that perspective? What is it, Brent, that if I was an investor and I came to give you my pitch, I had a company, what are you listening for when you have the Mount Sinai headspace on? What would I say that would excite you, and what would I say that doesn't excite you?
So, first and foremost, we are a community-based organization focusing on trying to help our patients be well and get better. And so the things that excite us are those initiatives and those projects that are going to move the needle on this vast population that Mount Sinai has of sick people who are trying to stay well across the city of New York. Unfortunately, healthcare is unbelievably complex, and increasingly, the amount of focus is on how do we manage our operations more efficiently so we can take better care of patients, we can see more patients, and we can maintain a margin in doing so because it's really hard with all of the changes in healthcare and in healthcare policy to be able to continue to go and meet patients' needs when the costs of delivering care keep on going up and up and up. And so the first thing that we look for when it comes to the investments that we're evaluating is how can Mount Sinai use this solution to either help us cut costs that are unnecessary and deliver high quality care, or enable us to generate alternative revenue. And I'll tell you that I think the focus right now is really on diversification of our revenue streams. Patient service revenue continues to decrease because of changes to both state and federal policy. And our costs continue to go up at a much higher rate than reimbursement does. And so we need to start thinking about how do we take cost centers that have traditionally been a necessary evil of delivering care and find ways to commercialize them to generate revenue, or where we are potentially sharing in some of the revenue streams that historically we've handed over to third parties. So
So,
rethinking what do we keep in-house versus what are we contracting out to external vendors?
right. Okay. There's a lot in there. Let me take some of it apart. But first of all, I probably should have said this at the outset. When you're giving me examples, no one in the audience should think this is what Mount Sinai is planning on doing. You're speaking as an individual, not on behalf of specific projects. But when you say alternative resources and diversification, break that down. What does that mean to a layperson?
Yeah, so academic medical centers focus tremendously on tertiary care and research. And so I think for decades now, our interest has been, what do we need to do to make sure that our subspecialty care delivery enterprise is best positioned? And we were able to and willing to absorb costs where there was less efficiency among other parts of the health system because those parts of the health system enabled the tertiary care platform to be successful. Now that the margins in tertiary care continue to decrease, we need to be a lot more exacting in terms of our specialty care, our primary care, and the other gateways to entry into the health system. And so rather than potentially having no margin or losing money, it's more important that we are ensuring that they are being run efficiently and ideally with a margin. And so let's look at urgent care as an example. There are hundreds of urgent care centers across Manhattan. Mount Sinai had a very robust and continues to have a very robust primary care community. We have hundreds and hundreds of internal medicine doctors that see patients every day, helping them through their chronic care conditions. And so when urgent care started to become popular, what we saw was a lot of organizations opening up on street corners, taking very expensive leases to be on the ground floor. So it was very visible and easy to walk in as a patient to be seen for really low acuity care, low acuity treatment. We looked at urgent care and said to ourselves, that doesn't really align with our mission of being there for a patient, that there are other people who can sit there and, sign those big leases and run lots of advertisements in the subways. And when you stub a toe and you're worried it's broken, there's a place that you can quickly go and get that treated. And if you really need, the specialty care that Mount Sinai is able to provide around, orthopedics or rheumatology or something else entirely, podiatric care, that eventually you'll see us and we'll be there for you to be able to meet your needs. As we're thinking now in terms of how we deliver care in the city of New York, we recognize that urgent care has really shifted in terms of how patients interact with it, that it's a way for people to access the care system on a case-by-case basis and not necessarily where they're looking to get longitudinal care for chronic care management. And so where we were working with urgent care centers historically, potentially, not potentially, but in reality, there was no opportunity for us to be able to make money in urgent care. We thought urgent care is something that will refer business to us if and when those patients need to get that specialty treatment that we're able to provide, that we have a whole, department to be able to meet the needs of. Now, as we're thinking about how care is shifting, how expectations are shifting, how payers are shifting, we have to go and scrutinize what exactly is that front door in which patients engage with the health system. And is there ways for us, whether through urgent care or telemedicine or home-based care, for us to be able to be that first point of contact for patients across the city of New York? And then how do we do that in a way that we're able to scale it successfully, run it efficiently, and rather than have it be sort of a cost center like marketing dollars, which I think is historically how a lot of health systems have looked at urgent care and sort of the front door of their enterprise for the last several decades. We don't have the luxury of doing that anymore. So now, rather than enter the market and say, oh, there's 47 urgent care centers on the Upper East Side, we're going to add a 48th, we're taking a step back, looking at where patients are trying to access the health system through all these different modalities, whether it's health apps on their phone or telehealth services or through community-based organizations or through urgent care centers, and find the right partner for us to work with in a collaborative and potentially financial joint venture in order for those patients to have a seamless experience from end to end where we're confident that the quality of care being delivered meets the expectations of Mount Sinai Health System.
So it sounds like if you were advising any system or maybe any healthcare investor, it's before you start looking at EBITDAs and this, decide what is your mission, right? There's a mission component, especially for a not-for-profit venture arm, but mission sounds like it's an overriding issue. Is that right?
Absolutely. The last thing we want to do is make an investment in some new part of the care delivery system that's going to drive up costs for our patients. It's a non-starter. It's not why we've been in business for 150 years. We are part of this community. It would be very easy for us to jump on sort of the, exciting, concierge medicine thing du jour, which could be tremendously profitable, but ultimately may hurt the care delivery for New Yorkers. And so we want to be really thoughtful about what it is that we are backing and making sure that does align with our mission. And that's what separates us from for-profit healthcare. And
Right.
there are some amazing companies out there that are providing for-profit healthcare, and they're meeting, a special group of patients where they are. That isn't the mission of the health system. Mount Sinai is here to treat the entire community.
And let me flip that then. Let's say I have a product which I don't, which I wish I did, but I have a product that I want to introduce to Mount Sinai. Might your mission, and it's a great product in that, let's say it's some kind of diabetic, you know,
Say artificial intelligence. Say
artificial,
machine learning.
right, machine learning, sure.
Oh, we're so excited.
Yeah,
Well,
yeah,
that's
yeah,
where do
right.
we start?
That's the word. But if it's something where
Yeah.
the return isn't great, but it can really, or maybe not at all, but it can really help wellness. So the EBITDA is not there, the financials is not there, but the wellness mission is that a factor that you might
Yeah,
consider?
absolutely. Absolutely. We made an investment in a uh, uh, medically tailored food company. And this is a company that designs menus, diets for patients for their very specific disease. You have kidney disease, there's certain things you can eat, there's certain things you should avoid. If you have inflammatory bowel disease, there's different things you can eat and different things you can avoid from the kidney patients.
Right.
And the goal of us partnering with this company was that the feedback we were getting from our nutritionists, from our registered dietitians, from our gastroenterologists, from our primary care doctors is so many of our patients are walking in the door with an acute issue that's tied to diet because they ate something that is going to cause inflammation in the case of the inflammatory bowel patient, or is causing longer term issues for our chronic care patients, whether it's diabetes or kidney disease or heart disease, that if they were eating food that met the nutritional guidelines of the chronic disease that they have, it would result in them avoiding hospitalization, avoiding emergency room visits, and avoiding having to see a Mount Sinai doctor or go get more labs done and more workups and more pathology, again, which all drives cost both to them, to their employer, and to the health system. And so our investment in that company was made because our clinicians were saying that this was the right thing for our patients. Now, if we were purely, profit motivated, the last thing we would want is for these patients not to be walking into the door of our medical clinics and of our hospital. But that's not what the right thing is for our community. And so that's why we backed this company, which is, I think, serving about 5,000 patients a week now across the state of New York and treating patients who are historically underserved, who don't have the means financially to be able to afford this. And they were able to work with the state of New York to develop programs. And so that for us, we saw the need of our patients, the demand from our clinicians, saying that this is something that is going to make a material difference on the outcomes of these patients, and we felt that that was the right investment to make.
So I'm going to come back to, because you mentioned two things. One, I'm going to take a tangent on. Sounds like your ears are open to the physician community, that you're getting a lot of input from them.
Absolutely. So a lot of venture investments are made by going out, especially in corporate settings, corporate strategic venture investors, people who work at whether it's Boeing or New York Presbyterian or Optum. They will go out and they will look in the market and see what's interesting and what's exciting. They'll find some solution that really speaks to them, and then they'll bring it back to their stakeholders and say, "What do you think of this?" That is not Mount Sinai Ventures investment thesis. We don't have the bandwidth, and frankly, because of where we are in the city of New York, because of the incredible brand that Mount Sinai has, and because we have tens of thousands of incredibly smart people, academics, clinicians, and physicians who are inundated with solutions. They're going to conferences, they're reading research, they're working with students who go on and develop companies. There are so many insights that are already rattling around within the health system. What my team does is we actually look internally and we go and speak to the chairs of the departments and the frontline workers and the people in administration at our community hospitals and say, what are you using right now that you're excited about? What are you thinking about adopting right now that you think will be a game changer for you, for your patients, for the hospital? And then based upon that feedback, we're going and making investments. And how that helps us, I think, and why, frankly, we've been so successful financially as an investment vehicle, is that it's cut down on the timeline that it takes to evaluate and diligence a product. Rather than me bringing something to somebody and having to wait for them to find time to look at it and then give me that feedback, they've already done that filtering and that analysis. And then at that point in time, I can go to the market and say, all right, well, how is this solution that this, Mount Sinai employees are so excited about? How is this different than what else is in the market? What are other people using? We have this amazing community of other hospital venture funds called the Strategic Venture Group. We have about 66 members. We meet monthly. So I talk to my colleagues at other hospitals that do what I do and say, are you looking in this space? What are you seeing in this space? Are you excited about it? And then taking that feedback and making the decision about whether or not it's the right investment for the health system, again, with the goal of a financial return in that scenario.
And does it, are there different considerations if a doctor comes to you and says, I've created this, or this is my verse, hey, this is a great doodad. If you could find me one that did this, I'd be interested. So let's take the first one.
Yeah, absolutely. So there's an entire team at Mount Sinai focused on what we refer to as tech transfer, taking Mount Sinai intellectual property, taking ideas and solutions and uh, 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 what's the word I'm looking for here? Um, Medical discovery and incubating it, licensing it, commercializing it into the market. And there's all sorts of policies and programs and rubrics in place to make sure that there isn't a conflict of interest between that invention was the word I was looking for, between that inventor, who may be a doctor, and their patients. Now, historically, pills, potions, lotions, medical devices, implants. These are things that have very, very, very long development life cycles. So if a physician, through their research and through their day-to-day work, realized that they had a better doohickey and they brought it to Mount Sinai Mount Sinai Innovation Partners, and Mount Sinai Innovation Partners said, oh, there's a real opportunity here for us to bring this to the market, it would take 5, 10, 15 years before that device was actually sitting on a shelf. Not only do all the research and development needs to be done, but all of the clinical trials work and FDA approvals and the like. It's a very, very long time frame. And usually by the time that product hit the shelf, that physician was so far removed from the financial remuneration of the actual thing that it was easy to have confidence that if there was indeed a knee joint that the doctor had invented and the doctor was an orthopedist, every knee joint that doctor doesn't necessarily mean another dollar in that doctor's pocket because they'd already had their liquidity event, so to speak, years earlier. With technology, and especially with artificial intelligence, that life cycle from idea to invention to a sellable good is like weeks. It takes nothing with digital health solutions and the like to be able to have that idea and bring it to the market. And that's where it gets really, really tricky. And that's where I think my colleagues and I across the United States, when we're looking at making investments, we need to be very thoughtful and very careful about whether or not we are inadvertently creating conflicts of interest. And so my team spends a lot of time in the diligence process to understand whether or not the individuals that we're working with have any sort of financial gain in what the product may be. And that can come in a lot of different flavors. They don't necessarily need to be an inventor. They could have some sort of advisor agreement or consulting arrangement and get shares in the company for providing those services. And when that's the case, we don't move forward. And there have been lots of great opportunities that Mount Sinai Ventures could have invested in the company or product, but it turned out that somebody within the organization had an arrangement in place. And we thought that the optics of it, whether or not you could manage that conflict, the optics of it just don't look good. And we've seen a lot of our colleagues at other hospitals get in trouble because of those optics. And so we're very, very conservative about that. We make sure that all the disclosures are up front. And indeed, if it turns out that one of these conflicts exists, generally we don't make an investment because the last thing we want to do is impugn the trust that our patients in the community have on us. And that's just the circumstances of corporate venture. If we were sitting at one of the institutional venture funds like Sequoia or Bessemer, it wouldn't matter. But we don't have that luxury, and those are the breaks.
So do most of the people who are on your advisory committees, or the other hospitals, Do they have like at the end of the road a final committee which is looking at like 10 different projects and choosing this one but not that one? Is there a screening process at the end? Who makes the final decision is really where I'm driving at.
Yeah, so I mean, in terms of workflow, the screening process happens actually a lot farther up front. So we are constantly going back to members of executive leadership, and it varies depending upon what the solution is, to make sure that we are on the right path, both in terms of this being the best solution for the problem that we have, as well as it being the best solution for Mount Sinai based upon Sinai's infrastructure. Because I have an example of a company that we found years ago that was really interesting around patient registration. So when you go into the doctor's office, all the forms you have to fill out, and all of the paperwork, and then collecting the patient's copay and all the rest of it. It's very cumbersome. It's very slow. It slows down kind of throughput in the waiting room. It's not pleasant for the patients. And we found a solution that was really elegant and met a lot of our needs, and got great feedback from the patients. We piloted it, but it turned out that it didn't work with our electronic health record.
Wow.
And so it didn't really matter how great it was in the front end, that it was not on the roadmap of the electronic health record for this, $9 billion health system, meant that it was really a non-starter. So after we got through the pilot and came to realize that the integration to make it communicate with Epic was going to be too onerous and too fraught, we decided not to move forward. And so there's a lot of steps along the way that you have to constantly check to make sure it's aligned. We spent the last 18 months working on a pharmacy solution, and it was a very long slog in terms of diligence, a very long slog in terms of contract negotiation. And frankly, during that time, another company entered the market, and entered the market in a much more exciting way with a much better solution. And so, although we had done all of this work, it wasn't going to be the best fit, the best solution for the problems that Mount Sinai was trying to face. And so ultimately, we walked away. And I have to say, that's a hard thing to do. I have a team of really, really smart investors that I'm incredibly fortunate to be able to work with. And it's a hard lesson to not get too emotionally attached to the companies and to the founders and entrepreneurs, to your counterparts, because you do work very closely with them during this process of evaluating an investment. And you sort of have this team spirit about, wanting to accomplish something.
Right,
At the end
right.
of the day, it wasn't going to be the best product for what the needs were for the health system. And so we had to say, you know what, I'm so sorry, but we got to this point, we're not moving forward.
Yeah,
That's a hard thing to do. And I don't think I've seen colleagues of mine at other investment funds um, get too committed emotionally and not be able to walk away. And that's hard. That's really
yeah,
hard.
I see it, especially when I'm working with early stage companies. I call it deal fever, right? Like they just need to do it for the sake of doing it. I can't look myself in the mirror and say something's changed. We just shouldn't go forward. It's a hard thing to do.
Yeah,
But
there's. I want to comment that for just a second because it's come up in different ways in the course of my career here. When I first got here, I came out of investment banking and I did some time in public health, and then I came to Mount Sinai, and I put on my old, investment banker hat. That expectation that things are going to move very quickly and that we're going to get a deal done. When I initially started, I was really aggravated by the bureaucracy of the health system. I would lose investment opportunities because it took us too long to do the diligence, took us too long to negotiate the contracts, that the window to invest closed. We missed the opportunity to invest. And I remember being really frustrated by that when I first started doing this. And then a couple things happened where deals actually didn't work out. That companies that we were really excited about investing in turned out weren't good companies, had made mistakes that we had not picked up on during our diligence. I would argue we didn't have the capacity to pick up on during our diligence. And so we missed those investment opportunities. And I think we saved money because of it. And also, I began to see that there are times when during that diligence process, things are uncovered that we realized weren't a good fit for us from a reputational standpoint or from an infrastructure standpoint for us to have been actually successful at the end of the day. And so I don't begrudge the bureaucracy. It's there for a reason.
to slow
We
you.
are a massive public community service organization. We're a huge charity. We treat millions of people, and they all look to us with this expectation that they can trust that when they walk into one of our clinics, that all of the tools there work and are the best tools for them. And so it is incredibly important that these institutions like Mount Sinai take the unfortunate but very necessary pace in order to make sure that we are making the best decision. And had we rushed those decisions earlier in my career, not only would we have lost money, but I think we really would have impacted the faith and trust of our patients and of our community.
Yeah, so for those of my physician investors who are listening out there, it's very important. It's not just, I think, for a large not-for-profit investment arm, but it's for all deals. If it can't wait till tomorrow, it's a problem. One of my mentors once said, sometimes the best deal you do is the one you don't do, right?
Yeah.
Just slow down, right? And sometimes the slow down, like as you described, could cost you an opportunity. But more often than not, it's been my experience, it actually could save you a heartache. You know?
Yeah.
But
So thinking about the other part of our portfolio that you and I have had a chance to work together, Mount Sinai Ventures also invests in care delivery companies, surgery centers, diagnostic endoscopy centers, some urgent care. Last year, we actually invested and co-built an anesthesia company. Um, you know, we are very slow and very exacting in that process for all of the reasons that I've bored you with already. And I do see a part of our job for my team is working with these, private equity backed operators to help them understand what the expectations are at the very beginning of the process. And we try to be totally transparent that how long these timelines are going to be. There was an old story about in the negotiations coming out of the Vietnam War that the Americans were all in hotel rooms and the Vietnamese negotiators bought a house. We need to be realistic and help our partners that we're negotiating with understand that it's going to be a very long time before we get this thing off the ground. And when we do, it's going to be great and we're going to be committed and we're not going anywhere. But helping them manage those expectations. And there are certain partners who've made it very clear that they don't have those kinds of time frames. And so the other part of our team's role is helping our colleagues at the hospital understand what the expectations and needs of our partners. And just looking at the private equity groups that are interested in ambulatory surgery centers, for example, they have a fund that has 10 years on it on average. It takes them a couple years to start making investments. And then usually before the fund closes, say in the seventh or eighth year, they're really thinking hard about divesting and bringing liquidity back because that's what their investors expect. And so when we meet a private equity group that's on, their third or fourth fund, and they're at the 5-year mark, the halfway point in the life cycle of their fund, when they come in to work with us, if it's going to take us 2 years to close, they're already going to be at the point of divestment.
yeah, they're gone.
This is not going to be the right fit. And so helping our health system leadership understand that if you want to work with this group, if you want to pursue this strategy, we're going to have to move a lot more quickly in order to match what their expectations are, helping them understand why those expectations exist, and then be realistic about it, that the people that we're working with today are not going to be the people we're going to be working with in 5 years, that they have the explicit mandate to buy these companies, make these investments, grow them, and to then sell them to somebody else. And so much of our job now is how do we build these joint ventures in a way, recognizing that we're going to be there for another 150 years, but our partners are going to change. And so, working frankly with law firms like Garfunkel Wild to structure these deals appropriately, enable us to have the confidence that not only are we meeting our financial goals in these investments, but we're also aligning with the mission of this nonprofit health system
Right.
around the longevity of these investments.
But it would seem to me, again, if we have physician investors listening to this, which I know there are, it sounds to me, tell me if you think putting this together from what you just said is true or how true it is. If you're looking to flip something, you have a great idea or you develop something, you want to flip it and get rich quick, probably go to the private equities because that's their perspective. If you have something that you want to be your baby and grow and really create a legacy for it, maybe a not-for-profit investment arm is a better option.
I look at it a little bit differently.
Okay?
I think you can have both partners in these investments. And certainly that's been the case in my portfolio. And I think for your physician investors, the thing that they need to be realistic about is that they are the engine for growth in these companies.
Interesting.
So anyone coming in with an expectation of eventually selling the business is not expecting that those physicians are going anywhere. So there may be opportunities for a partial liquidity event where they get some return on their investment.
I see.
But I think those physician investors really need to be looking at what is the operating profits that they're going to be getting their distributions from, that they're going to be making their money from, and not to be misled to think that there's going to be some pot of gold at an end of a rainbow in 7 to 10 years, because that pot of gold will be there, but it's not going to be shared with the physician investors, because whoever is benefiting from that pot of gold is selling the idea that those physician investors are going to be there beyond the transaction.
I see.
And I think that's been really hard. I think there was 25 years ago with the HMOs, this expectation that there were these big payouts, these big liquidity events, everyone made a bunch of money and then retired. And that's not clearly that didn't work out. But what we've seen in the last 15 years, especially with the increase in private capital in the New York market, because corporate practice and medicine laws really kept that out for a long time. But what we've seen in sort of the last 10 or 15 years in the New York market is these groups come in, they build these businesses up, either through better negotiation of payer contracts, better negotiation of supplies, better operational efficiency because they're professional managers, and then they sell to another entity that comes in and buys them out, but only buys out a very small percent of the physician investors who are in there. I think the other thing that's a big part of the experience for physician investors is recognizing the life cycle of these businesses. That you're going to come in as you are kind of hitting the peak of your career, and you're going to be brought in because you're at the peak of your career. And that as you're coming towards the end of your career, that there's going to be a natural attrition and a time when you're going to exit that business. And that pot of gold, that big liquidity event, that big profit moment is going to happen either before you leave or after you've left, but not at the moment that you're leaving. And I think that's really hard for physician investors to come to terms with, because I think there were these misexpectations going into these transactions that when you go to retire, that's the moment you're going to make all of the money. That's
All the
just not
chips
the
are pushed
case.
forward. All the chips pushed forward, not
Yeah,
giving. Yeah.
it's not the case, because effectively you no longer have the value to that business that you did when you joined at the peak of your career. And so you're bought out at the value that you provide in that moment, which is very little. And I've seen that many times. And so I'm in a very fortunate position. Also, to be clear, I have no upside in any transactions. I'm a flat salaried employee of this nonprofit health system. And so whether or not, these businesses make lots of money or a little bit of money or what have you, it has no financial impact on me personally. And so it's easy for me when we're putting these projects together. And I literally had this conversation yesterday with a urologist looking to join one of our companies. I said, look, I just want to be really clear here about what this is and what's going to happen, because the last thing I want is for you to be disappointed. I don't make money off your disappointment. There are other people involved in these transactions who might, but not me. But what I care about the most is we're building this business together. We're going into a partnership together. You need to be able to trust me throughout the arc of this business with us both as investors in it. And so I want to be really clear up front about how this is going to work, where you are going to make money and where you're not going to make money. Because I think, unfortunately, that some of these private equity backed operators have financially incented their teams in a way where they're less willing to be transparent with these doctors. And I've seen in meetings some of people mislead physicians, inadvertently or not, to get them to sort of sign up for the deal. And so I can't stress enough for the physician investors who are joining this how important it is to do your homework in advance and to really question who's providing you with this information. So many times I've seen physicians look across the table at the manager and say, "Oh well, you're in this with me, right? So you're looking out for my best interest," and it's just not the case.
Interesting. So that's something to be wary of if you're a physician investor. Well, we're almost out of time. I'm going to do rapid fire questions at you, okay? Because
Okay.
with too much experience, not for me not to take advantage of you. So you mentioned AI a couple of times. We had a session last year. We didn't do that session this year. Last year, the theme was AI is going to revolutionize the world. The whole world is going to be different. Your perspective on that? Yes, no, where are we?
I think artificial intelligence is going to make a significant impact in the world. I think artificial intelligence is overhyped and there's over exuberance. We're overly exuberant on what artificial intelligence can do for healthcare. It is unbelievably complex. And I fear that the people who are building AI models don't understand healthcare well enough to be able to build them effectively for healthcare delivery.
Perfect.
This is a
Okay.
people business.
All right, perfect. Next one. I was wondering when you were speaking, will Mount Sinai or similar companies, investment arms, will they make silent purchases, or do they always have to be active? Do you have an appetite for just investing but not being an active investor in
Yeah,
crypto?
so there are different strategies. We have two. We have a strategic investment strategy, which is really around care delivery, and then the rest of it's a financial strategy where we're making investments in small companies that we think will sell in the next few years and bring a return back to us. Mount Sinai, like every hospital, has a impressive endowment with an incredible investment team that are really managing those kinds of investments. But we feel that we're a little bit uniquely positioned to identify direct investment opportunities that do have a financial gain.
I see. So you're on the active investor side, but there is an arm that is the silent investor. Got it. Okay. Last one, because I could talk to you all day. Last one. Pick not necessarily the top one, but what is a warning sign to you that your instincts go, wait a second, when somebody comes to you with an idea that because you talked about the doctors and needing to trust you, but there also goes the other way. You need to trust that partner, right? So what is it that somebody could do which you would say, I don't feel good about this?
The first thing is when I ask, who are your competitors in the market? And they say there are none.
Right.
That for me is the biggest red flag. Either they haven't done their homework or they're kidding themselves. There's an infinite number of competitors, and they may not be directly doing what it is that this company does, but they're providing some service in that space today that this company is looking to replace. They're effectively competing with them. And so that for me is kind of the big red flag. The other one is just, again, when it sounds too good to be true, it is.
Right.
If it's too complicated for my little brain to wrap itself around to understand like the business model and the revenue model, I often find that's because there isn't a functioning revenue model or business model.
Great. So, Brent, you have a very good brain. We'll leave it here. If somebody wanted to reach out to you, an investor, like, do they get your name off your Mount Sinai's website? Or
Yes, my email is public on the Mount Sinai website. It's one of the few, so I get lots of inbounds from investors and many, many patient complaints.
all right. Well, thank you so much, Brent, and have a great day. Appreciate it.
Thank you so much for the opportunity. Really great to join you today. Thank you.